dress up as the governor of Bengal to try and persuade this gentleman to eat. He, of course, did not eat. The point of the story is not that. The point is that they were trying very many different things, trying to understand what is going wrong with this person and trying to figure out what is the best way of doing it. Subsequently, of course, he was on nasogastric feeding for a long time. This is just for interest. This is the Colonel Mujibhai in a later period. What does Indian history have to teach us about this? Mabatha, who came from England to look at the hospitals, was actually quite strongly critical. He said the Indians have been unable to exercise the authority to enforce change. The only thing that they know is to lock up their worst patients. As an aside, in one of the reports, Gunjubhai of the Ranchi Mental Hospital has quoted Mabatha as being as praising the Ranchi Mental Hospital. 10 years later, Moore Taylor prepared another report on the functioning of mental hospitals. I'm not going to go into details there. All uniformly depressing, bleak, critical. It says the majority of mental hospitals in India are out of date and are designed for detention and safe custody without regard to curative treatment. The condition of many hospitals in India are disgraceful and have the makings of a public scandal. The National Human Rights Commission and NIMHANS in 1997 did a study which most of you are familiar. The fact that they were grossly understaffed, the fact that not much was happening in the form of care, that many hospitals did not have nurses, let alone psychologists, and so on and so forth, is something that all of us are very familiar with. Talking about rights in its own way, in its own very quiet and understated way, the report says that that rights were not accorded the highest priority, which is about as understated as you can get. In fact, to say that several areas that they were grossly violated. The stories you've heard time and again of people being kept naked and so on and so forth. We're not going to go into that. But the fact that there was gross abuse of the system is not understood. 10 years later, the next report is only marginally better. Understaffing is still rampant. Therapy is still inadequate. And while hospitals have shown some change, the slow pace of change, the administrative apathy of the government, the lack of insightful leadership and innovation presents a dismal picture, overshadowing the positive changes which are admittedly small. The fact that monitoring makes a difference, and the fact that the hospitals which are monitored by the Human Rights Commission as opposed to the ones that weren't, there's a difference. You can't see the details in the slide, but the changes are small. We come to the recommendations. And for the sake of brevity and for the sake of presentation, I'm only picking up on a few of the recommendations, which is that what are the recommendations? That continued monitoring is required. You stop to think about it for a moment. It's actually quite depressing. The first recommendation that a hospital will need to be continuously monitored by a Human Rights Commission to function. It's about as bad as it gets. Immediate downsizing, closure of the closed wards, abolition of custodial practices, enhancement of postgraduate training, active liaison of government and non-governmental organizations. Out of interest, if you look at the recommendations 40 years of, because after Wu Taylor's report, they also came out with the recommendations. What were the recommendations? Qualified and trained psychiatrists are needed. There's need for adequate staffing. Postgraduate training is required. Better trained nurses are needed. Better work therapy is needed. Better liaison is needed. And public awareness is needed. Let's go back a little further and look at Mabatha's report. This is 1938. What is it that they have recommended? It's eerily resonant of the same. First, of course, is that India is not ready for non-conditional order because of corruption. Every admission needs to be mandated by a magistrate. Certificates for detention are required. Improvement of condition for chronic patients is required. Increased training for mental health is required. Well-trained staff is required. Social workers are needed. Organized occupation for inpatient and training procedures is required. The recommendations are the same. Nothing really has changed.
So can you, is there anything back also before 1930?
Back? No, there isn't anything before that.
It is a loaded question. Why? Because in 1920, you changed the name from lunatic asylum to mental hospital. But nothing really has changed in practice.
Some changes are cosmetic more so than others. So where does this leave us? Is the answer closing down mental hospitals? Is the answer in some way has the answer in some ways already been given by the earlier presentation? Nimesh presented in the morning as to in what ways institutional care is, in a sense, reinventing itself, of how institutional care is looking at not just institutional care within the institution, but with outside the institution as well. And in many ways, in NIMHANS and in IBAS, this is what we're seeing. The fact that the majority of the mental hospitals are, to put it bluntly, abysmally run and have been abysmally run, and that huge systemic failures have happened. I don't think that anybody is going to deny. The question is not that. The question is, what are the alternatives? What are the other ways that we have? The fact of, in fact, if you look at this, the BBC documentary, and if you look at all the literature of that has followed a mental hospital closure, and what happens in poorly prepared and unprepared communities when mental hospitals close down, and actually people are just found out on the streets, it doesn't really solve anything. This is not to defend the situation in the mental hospitals as it has been so far. There is no defense for that. But the process of what is called, what Mangarama said was trans-institutionalization, which we have recognized in a big way. There isn't too much time, so I'm not going to talk about this. The really controversial community treatment programs, that the people who are released from mental hospitals and refuse to take treatment, that nursing teams will go forcibly to that person's house and ensure that that injection is given, the depot is given every 2 weeks, is in itself a huge issue. What are the answers? I don't have the answer. I don't know what the answers are. The fact that mental hospitals, the way that they've been run, or the history of the mental hospitals, the fact that this is in many ways terrible, we have no doubt about. We need to think of alternatives. Alternatives cannot be one. The alternative is not in some ways, as somebody was saying, that the burden of care to be shifted from the mental hospital to the family or to the woman at home, because as in many ways, as you read, the problem is that the family is not supportive, or the family does not exist, or the family is actively hostile. So these are, I think, things that we need to think about. And I'm going to stop here, and we'll go on with the rest of the sessions. Thank you very much.